How's it going, guys? Past level question, hematology, step 1, internal family, 2CK. 10-year-old girl, 1-month history, fatigue, a normocytic anemia here. Hemoglobin low at 10 should be 13 to 17.5 in non-menstruating females, and males 12 to 17.5 menstruating females. MCV should be 80 to 100. And then her father underwent a splenectomy, cholecystectomy when he was younger. What's most likely to be seen in this patient? Choice A, G6PD deficiency, wrong fucking answer. And you know it's wrong because it's X-linked recessive and it would be a boy, not a girl. So G6PD, an enzyme necessary for the production of NADPH, which is a reducing agent that protects RBC membranes against oxidative damage. So if you have deficiency of the enzyme, you can get hemolysis in the setting of a drug such as dapsone, primaquine, viral infection. You get unconjugated hyperbilirubinemia. You get bite cells. You can get Heinz bodies. They might give you an 8-year-old boy who had a recent viral infection, now has sclerolicterus, increased serum LDH. RBCs are packed with LDH, so if they give you a question where LDH is high, that can often reflect hemolysis. Choice A, wrong fucking answer. Choice B, pyruvate kinase deficiency, wrong fucking answer. Through this, you need to be a flagrant asshole because some of you have heard of this before, you're not sure how it presents. This is the second most common cause of hemolysis due to an enzyme deficiency after G6PD deficiency. Pyruvate kinase, last enzyme in glycolysis, converts phosphoryl pyruvate into pyruvate. And if you have deficiency of this enzyme, decreased ATP production leads to decreased sodium potassium ATP activities on RBC membranes, leading to sodium building up within the cell. Water stays with sodium, erythrocytic swelling, and hemolysis. I don't think I've ever really seen this tested much, maybe 1 to 2 questions tops across all the NBME exams for steps 1 and 2 combined, and it's a diagnosis of exclusion, meaning we eliminate to get there. Choice B, wrong fucking answer. Choice C, increased hemoglobin A2 HbF, wrong fucking answer, refers to beta thalassemia. Okay, so beta thalassemia, decreased production of the beta chain of hemoglobin, and so you're going to increase to compensate. You're going to have increased production of alpha-2, delta-2. That's just what hemoglobin A2 is. And HbF, fetal hemoglobin, alpha-2, gamma-2. So if they give you, let's say, a 12-line bullshit hematology question, the last line, they say, hemoglobin A2 is increased. Or they can just say, hemoglobin A2 and HbF are increased. You don't even need to read the question. You know they're talking about beta thalassemia. So obviously, if you have beta thalassemia major, that's a sick kid. They like teaching you beta thalassemia minor because that's going to be an adult who will often be misdiagnosed as having an iron deficiency anemia. So for example, you have a 32-year-old woman who has low MCV, low hemoglobin, microcytic anemia. 99% of the time, that's just IDA due to menses. Even if they tell you the menses are not heavy, it doesn't matter. That's often IDA, especially in family medicine forms. But 1% of the time, that can actually be thalassemia, where if you do iron studies, they're normal. So in thalassemia, what I want you to know, not just bullshit target cells, you can't use those as a crutch. You need to know thalassemia, alpha and beta for that matter. They present as a microcytic anemia despite a normal iron and ferritin, okay? And they can also tell you that it's a microcytic anemia that is non-responsive to iron supplementation. Choice C, wrong fucking answer. Choice D, increased erythrocytic osmotic fragility, correct answer. So diagnosis, hereditary spherocytosis, autosomal dominant, heterozygous mutation, anchorin, spectra, and band proteins, a cytoskeletal/cell membrane protein, and you get increased RBC fragility. Okay, so osmotic fragility test, eosin 5 Mehlmanmedical to diagnose. Now, they want you to know that it's a normocytic, normochromic anemia. Shows up in one of the NBME questions where they give you a micro, normo, macro, hypo, hyper, okay, all the different combinations, and it's normocytic, normochromic. So they like, because it's autosomal dominant, they like giving you, for instance, a father, mom who had history of splenectomy, cholecystectomy. So the spleen is constantly going to be eliminating the abnormally shaped RBCs, which can lead to not just an unconjugated hyperbilirubinemia, but an increased proclivity for calcium bilirubinate pigment stone cholelithiasis. So these patients can require cholecystectomy, and this can show up on the USMLE, especially 2CK. They can give you hereditary spherocytosis, and then They'll say, which of the following is the definitive treatment for this patient? And the answer can be choice C, splenectomy and cholecystectomy as one answer. And that sounds very overkill, but it can be an answer for the USMLE. You need to know Coombs test is negative for this because Coombs test means you have antibodies against RBCs. There's no antibodies against RBCs here. We said it's just anchorin spectrin band protein problem. If they give you spherocytes in a question with a positive Coombs test, however, that's hemolytic anemia that can occur due to a drug or infection. Okay, students, when they're first learning this stuff, they think it's an erratum. They'll tell you a kid had, and it's different from G6P deficiency, okay, where you get bite cells, Heinz bodies. You can sometimes get hemolytic anemia with antibodies, idiopathic antibodies against RBCs producing spherocytes, Coombs test positive, and students think it's an erratum because hereditary spherocytosis, it's wrong, okay? So let's just hop to the final answer choice here. Isolate increase in PGT, wrong fucking answer. It's going to refer to hemophilia A, B. So X-linked recessive. Okay, so deficiency factor 8, 9 respectively. And that's going to give you just the partial thromboplastin time elevation. They might tell you it's a boy. There's two ways hemophilia is going to present. Number one, school-age kid who has bleeding into the knee, hemarthrosis. They can say that maternal uncle died from mild head trauma. The second way it can present is a neonatal male who has excessive bleeding with circumcision. Choice E, wrong fucking answer. You know the deal. To make more content, I'm going to subscribe my channel. Appreciate your time. That's a